Good afternoon, everybody, and I want to welcome everybody that's in person and online to the final plenary presentation of the 2025 North American CF Conference. I'm hopeful that everyone has found the meeting both instructional as well as inspirational. Now, I'd be remiss if I did not acknowledge the efforts of Kirsten Oline and the entire meetings team for their behind-the-scenes logistical work necessary to accomplish such a large undertaking. Yes. I'd also like to acknowledge the Program Planning Committee and the session leaders for organizing a remarkable collection of content that we've been able to enjoy over the past couple of days. Please join me in recognizing them as well. So one of the most rewarding parts of the North American CF Conference for myself and others at the Foundation is recognizing scientists and clinicians who've dedicated their careers to advancing research for the improvement of the lives of people with CF. This year, I have the distinct honor of presenting the Dorothy Andersen and Paul de Sant'Agnese Distinguished Scientific Achievement Award, the highest recognition for research that is given by the Foundation, to a person whose contributions to our scientific understanding of CF through his own work and both direct and indirect guidance of others has been paramount in advancing life-changing therapies for people with CF. Doctors Dorothy Andersen and Paul de Sant'Agnese were pioneers of CF research informed by their own and others' clinical insights. Their observations and ultimately opinions had enormous impact upon the burgeoning field of CF research. This year's awardee shares many of those same attributes. I'm pleased to announce that the 2025 Andersen de Sant'Agnese Distinguished Scientific Achievement Award is presented to Dr. Jeffrey Wine. Jeff's work has extended ion transport abnormalities to airway exocrine gland dysfunction and for his many contributions in shaping the direction of CF research. Now, following a stint in the U.S. Air Force as an intelligence analyst, Dr. Wine received a psychology undergraduate degree from the University of Pittsburgh and a PhD in physiological psychology at UCLA. A Grass Foundation Fellowship in Neurophysiology took Jeff to the Marine Biological Laboratory at Woods Hole, after which he came to Stanford University's Biology Department for postdoctoral studies. His talents were quickly recognized, and after a single year of postdoctoral work, joined Stanford's psychology faculty. For the next 14 years, Jeff published in high-impact journals primarily about reflex responses in crayfish. Now, after Jeff's oldest child was born with CF in 1981, a redirection of his laboratory's focus was aided by a sabbatical in Paul Quinton's laboratory, and a long-term relationship was established. This fortunate interaction led to Jeff's focus upon the importance of submucosal gland anion transport to CF, including development with Nam Soo Ju of methods for visualizing and measuring native fluid secretion that has been adopted by multiple laboratories around the world. His investigations into tissue-level gland processes have informed concepts about airway disease pathogenesis and potential opportunities for minimally invasive CFTR modulator drug response monitoring via sweat chloride analysis. Jeff also collaborated with fellow Stanford investigator Ron Capito in one of the first studies to describe chemical rescue of delta F508 CFTR that was found to be additive to low temperature rescue. This was a prelude to triple combination therapy we heard the long-term benefits of during Plenary 1. Now, beyond his own studies that shaped our understanding of CF, Jeff has been instrumental in guiding the direction of future research, CF research, through 36 years of membership in the Foundation's Research and Research Training Committee, 23-year membership in the North American CF Conference Program Planning Committee, and more than 20 years as an external advisor to multiple research development programs, and a pioneering member of CFF's Vertex Advisory Panel that aided in the identification and advancement of Kalydeco and Orkambi, which validated CFTR as a drug target, supporting the subsequent development of Trikafta and Alyftrek, which many, including his eldest, are benefiting from today. Jeff, we thank you for your commitment to CF, the foundation, and all those that we serve. This commitment from you and those closest to you, your wife Marlene, daughters Jenny and Nita, and her partner Laura and their child Kai, has informed our understanding of CF, shaped the field's thinking of disease pathogenesis, and aided in advancing life-lengthening therapies for many. Jeff, congratulations.
Please welcome from the Cystic Fibrosis Foundation, Dr. J.P. Clancy, Senior Vice President for Clinical Research, and Namrata Patel, Program Specialist 2, Global CF.
Oh, my people. Oh, thank you, Chris, and congratulations, Dr. Wine, on this well-deserved honor. Before I continue, I have to say one thing. Is Dr. Uhler still here? Where are you? Where are you? You are my new shoe consultant. I just wanted to get that out there. So, anyway, all kidding aside, today, thank you for joining us. Our third plenary today is entitled Addressing Health Disparities and Transforming the International Landscape of Cystic Fibrosis Care. To help me introduce, I'm joined today by Namrata Patel, Program Specialist in Clinical Affairs focused on care-related international CF programs here at the Foundation. So happy to have you up here. Thank you. Before we get started, though, I wanted to stop and acknowledge that earlier at North American CF Conference, a group of families announced that a generic version of ETI may become available from Bangladesh. And now, while today's plenary was prepared actually before this announcement and does not directly address the topic so much, I do believe that you'll find the spirit of our discussion today really reflects a shared commitment to ensuring that all people with CF, no matter where they live, can benefit from research and care advances. So, Namrata?
Thank you, everyone. Thank you, JP, and good afternoon. It is my great pleasure to help introduce today's plenary on the role of health equity in CF care and innovative approaches in improving CF care delivery in low and middle income countries as we strive for quality care for all people with CF. These are complex topics that have been growing in importance within and beyond the CF community. It is abundantly clear that this is a topic that our care and research communities are deeply invested in, and one that is essential to address to achieve our ultimate mission to finding a cure for all people with CF.
Yeah, I couldn't agree more, Namrata. Health-related inequities give rise to health disparities and across the spectrum of CF research and care. To be honest, examining health disparities can quickly become overwhelming, particularly when we try to pivot and implement meaningful ways to break down these barriers. The CF Foundation is absolutely committed to both curing CF and providing all people with CF the opportunity to lead long and fulfilling lives. Part of this includes access to quality health care and life-changing therapies like CFTR modulators. We are encouraged by progress in modulator access internationally, and we also acknowledge that much more work is needed globally, particularly in low and middle income countries, to ensure that all those who can benefit will benefit.
Well said, JP. Health inequities are pervasive throughout CF, our healthcare systems, and our societies at large. How can we actually make real progress against such a formidable foe? I believe today's plenary speakers take this question head on, identifying the challenges and offering actionable solutions. These problems are not solved easily or quickly, but we hope that the presentations today make you feel empowered to be a part of this important work.
Our first speaker is Jennifer Taylor-Kauser. She is a tenured professor of medicine and pediatrics at National Jewish Health in Denver, Colorado. She received her undergraduate degree in human biology from Stanford University, and then completed her doctorate in medicine, combined residency in internal medicine and pediatrics, and her combined fellowship in adult and pediatric pulmonary medicine at Duke University. I had to read that, that was a lot. She has led numerous national and international research programs and is an elected member of the American Society of Clinical Investigation. Recent accolades include the ATS Presidential Commendation Award and the Distinguished Achievement Award. I also wanted to highlight Jen's commitment to racial justice in academic medicine and for people with CF, including her leadership in her institution, with the CFF, and nationally. She is a mentor to many, and she collaborates extensively with the CF research community, including her expertise in orangutan lung health, so she's got it all. Dr. Taylor-Kauser will highlight many of the biologic, socioeconomic, and systemic factors that contribute to CF-related disparities, and she will share clear and distinct actions that are being successfully applied with the goal of overcoming these barriers. Our second speaker is Dr. Hector Gutierrez, who has worked hand in hand with Namrata and the CF Foundation for nearly a decade to advance CF care and quality improvement in Latin America.
Dr. Gutierrez is a professor of pediatrics and chief of pediatric pulmonary and sleep medicine at the University of Alabama at Birmingham. He holds the Raymond K. Lyrane Endowed Chair and also serves as the associate director of the Pediatric CF Center. Dr. Gutierrez approached the CF Foundation several years ago, seeing an opportunity to improve care in lower resource South American countries. Since then, he and his team at UFB have made amazing progress in partnership with care providers in Chile and Argentina, and to improve care delivery and outcomes for people in many Latin American countries. A physician scientist and innovator in healthcare system, Dr. Gutierrez has dedicated his career to advancing the quality, value, and equity of CF care worldwide. Trained in Chile, Maryland, and Alabama, he has advanced expertise in healthcare delivery improvement, quality, and leadership, and brings a unique perspective that bridges clinical excellence, implementation science, and global health innovation. He is the lead investigator of several global health initiatives funded by the Cystic Fibrosis Foundation, and that have successfully built regional capacity across Latin America and beyond. Today's talk unequivocally demonstrates that outcomes can improve for people with CF in resource-limited countries, and that core principles to these improvements are effective partnership and a focus on basic care.
Thank you, Namrata. I can't wait to get this plenary started, but before I do, I needed to do something. I need to welcome the CF care teams from Santiago, Viña del Mar, Buenos Aires, Mendoza, Cordoba, Tucumán, Formosa, San Luis, and Santa Fe provinces who are here with us today as we share a glimpse into their amazing work. So thank you. So on that note, please join me in welcoming my friend, Dr. Taylor-Kauser, to the stage for our third plenary presentation.
Thank you, JP, particularly for inviting me back to do a second plenary in person. And thanks to all of you who have stayed till the very last session on the very last day, and to my parents and my brother and friends who are here, as well as all of you joining us online, including my sister who couldn't be here, and friends that are like family. All the opinions expressed today will be my own. These are my disclosures, the most relevant of which is that I have done clinical trials and consulting design for Vertex. So these are our objectives for the first half. Describe the biological, socioeconomic, and systemic factors influencing CF outcomes, and identify actionable strategies to improve those outcomes. To understand how recent advances in CF care have unevenly expanded the possibilities for people with CF. In the second half, to understand the barriers that international care teams face in the efforts to achieve partnership. And then to identify the global adaptations in CF care in low resource settings that can be leveraged to improve outcomes for everyone with cystic fibrosis. So I'd like to do some level setting before we get started. In the words of the great Dr. Maya Angelou, do the best you can until you know better. Then when you know better, do better. So over the next 30 minutes, I hope to provide you with the information that will help you know better so we can all do better. It's also essential to remember our mission. The mission of the Cystic Fibrosis Foundation is to cure cystic fibrosis and to provide all people with CF the opportunity to lead long, fulfilling lives. So with that in mind, let's dive in. As we start to think about the opportunity for everyone to have optimal health care outcomes and the barriers to achieving that goal, there are some critical concepts that need to be defined. In order to do that, I'm going to use the analogy of three people trying to watch a baseball game. In that first image, unfortunately, it's our current reality, where not everybody can see the baseball game because there are barriers in the way. An equal solution to that problem would be to give every single one of those people one box. But you can see the child still can't see over the fence. The person in the middle can now see over, and the person that was on the right never needed it in the first place. An equitable solution to the problem would be to give every single person what they need. So in this case, the child gets 2 boxes, the person in the middle 1, and the person who didn't need one doesn't get one. The place that we really want to get to is justice, where that barrier is removed so everyone can watch it from the very beginning. Another critical concept for us to understand as we move into this is that race, and ethnicity for that matter, is a social construct. It's socially and politically defined without biological basis. Dr. Svante Pabo said that even between Africa and Europe, there is not a single absolute genetic difference, meaning no single variant or mutation, where all Africans have one variant and all Europeans another one, even when recent migration is disregarded. Dr. Michael Udell said, if you make clinical predictions based on somebody's race, you're going to be wrong a good chunk of the time. For example, in cystic fibrosis, which is an underdiagnosed in people of African ancestry because it is thought of as a white disease. Although race and ethnicity are social constructs, they are often proxies for racism and for bias, and therefore part of the social determinants of health. Those factors that are outside someone's biology but have profound impacts on their health outcomes. So for example, if you have no access to quality health care in your area, your outcomes will be worse. If you live in a neighborhood where you're exposed to a lot of pollution, particularly if you have a respiratory disease, your outcomes will be worse. If you live in a community where there's a lot of crime and you can't get outside to exercise and play, your health outcomes will be worse. If you can't afford to buy your medications or the gas you need to get to the doctor's office, your health outcomes will be worse. And finally, if you don't have high quality education in your area and you can't understand what's being asked of you in terms of your medications and your care, your health outcomes will be worse. So we start with the social constructs of race and ethnicity. Racism, discrimination, segregation lead to structural inequities and societal injustices. And these impact the social determinants of health. You then get health disparities, these preventable differences, and therefore adverse health outcomes. That's a lot to take in. So I'd like to take a moment to give you a very concrete example of when racism and bias led to structural barriers that directly affected health outcomes. Back in the 1930s, a US federal agency created a 4-tiered system in which they divided neighborhoods into green being the best, it's a great area to give home loans, to red being absolutely no, it's too risky, don't give anyone in that area home loans. The people living in those red areas were Black and brown people. So not only were they deprived of the opportunity to gain wealth through owning a home, they were also segregated into the areas with the poorest resources and the most pollution. Fast forward about 90 years, when Dr. Wenzel and colleagues went back and looked at these neighborhoods and said, how are people's asthma outcomes based on these different neighborhoods? And regardless of which measure she used, whether it was uncontrolled severe asthma or missed school and work from asthma symptoms, the people currently living in those neighborhoods had the worst health outcomes. So again, racism and bias led to systemic barriers, and 90 years later, that's still affecting people's health outcomes. Another factor that can impair your health outcomes is a provider and patient and family relationship, and if there is distrust there. But there is plenty of reason, both historical and ongoing, for that mistrust, and I'm going to give you a few examples. This surgeon was trying to perfect a technique to repair a complication of vaginal delivery. To do that, he was practicing this technique on enslaved Black women without their consent and without anesthesia. We often think about Brown versus the Board of Education and school segregation, but it wasn't just schools that were segregated. Hospitals were also segregated, so those people who were Black and brown were forced to go to the hospitals with the poorest resources. The Tuskegee experiments were funded by the US government. Men were told that they were going to be treated for syphilis, but instead were observed. Many of them died, and their spouses became ill. Henrietta Lacks was an unfortunate woman who died very young of an aggressive cervical cancer. When she died, doctors at the institution took her cells and began to use them for experiments. Because they were so effective, they started sending them to researchers around the world. They're known as HeLa cells for Henrietta Lacks. Again, these were taken without her consent, nor that of her family. And you might think those are examples from a relatively long time ago. But currently in the US, the death rate for non-Hispanic Black women in pregnancy is 3.5 times that of white women. And recently, both Beyonce and Serena Williams, both people with education and the financial means to get the best health care, talked about their biased experience in medicine that nearly led to their deaths. Racial bias in medicine continues to impact diagnosis and care. For example, until very recently, we used race-based corrections to measure spirometry and calculate it. So that underestimated disease severity in people who were Black. We've known since the 1980s that the way pulse oximeters have been designed is less effective in people with darker skin. This was particularly relevant during the COVID pandemic when the way we screened people to determine whether or not they should be admitted to the hospital was using pulse oximetry. So even if an individual provider wasn't biased, they were still providing suboptimal care to their patients because it was built into the system. To this point, I really focused on how race and ethnicity and racism and bias and other social determinants of health affect medicine in general. But I'd like to switch the focus to CF and how it's affected people with CF. Back in 1938, Dr. Dorothy Andersen was the first person to describe cystic fibrosis as a clinical entity. In her seminal paper, she noted a Black child and a Hispanic child. And she said the racial and geographic distribution of the disease was wide. But this message has been ignored, and it's been taught that this disease only occurs in people who are white. And that has had profound impacts for Black, Indigenous, and people of color. Let me give you some examples. You heard yesterday from Al that the reason we do newborn screening in every state in the US and DC is because early diagnosis and intervention improves health outcomes. But currently, the commonly used newborn screening panels are really likely to miss those rare mutations that are more likely to occur in people who are Black, Indigenous, and people of color, depriving them of the opportunity for early diagnosis and care. Furthermore, if they're missed on newborn screen, even if they go to the doctor with classic signs and symptoms of CF, it's still unlikely to be considered that they have cystic fibrosis if they are not white. This middle picture is Mr. Terry White, who wasn't diagnosed with CF until he was 54 years old. And one physician actually said to him, if you weren't Black, I'd say you had the classic signs of CF. Let me give you other examples. Dr. Megan McGarry showed that Hispanic children are more likely to acquire Pseudomonas at a younger age. Dr. McCauley went on to show that you were more likely to die in childhood if you were Black, Indigenous, or a person of color. Dr. Kathy Ramos showed that you were less likely to get listed for lung transplantation if you were Black, Indigenous, or a person of color. And Dr. Don Hayes went on to show that in this era that you heard about on Monday, where people probably need transplants much less, that's true if you are white. But if you are Black, Indigenous, or a person of color, you're still likely to need a lung transplant. There are also disparities in eligibility for Alex-Tez-Iva or Trikafta. Doctors McGarry and McCauley showed that based on the registry, you were less likely to be mutation eligible for Trikafta if you were Black, Indigenous, or a person of color. Dr. Cam Jordan went on to show that you're less likely, even when eligible, to be prescribed Alex-Tez-Iva, and you're likely to get that at a much later date than your white counterparts. And this impacts patient experience. In this community outreach effort, people were actually asked how they were feeling about their experience with the CF community. This person said, haven't touched base with the Rocky Mountain chapter here. For me, I feel like being Puerto Rican, a person of color, I'm probably one of the few people here in the area that's been diagnosed, and I'd stick out like a sore thumb in all these white people. Because I only have 30 minutes today, I didn't focus on all the possible identities that impact your care, but I would like to show you this quote. While I don't typically think about bringing my queerness to the table at CF events, It has been healing to be visible in these spaces, and probably also good for younger ones to see. And I will point out that in a study called Pride CF, led by Dr. Greg Sawicki and others, they are specifically studying what it means to be a member of the LGBTQ plus community and how that interfaces with your cystic fibrosis. So more to come on that study. So I mentioned that back in 1938, Dr. Andersen described CF in a child who was Black and in one who was Hispanic. So what do our demographics look like in the US today? This is based on the 2024 registry. You can see that about 4% of people identify as other, which generally includes people who are Native American, Pacific Islander, South and East Asian. About 5% of people identify as Black or African American. About 9.5% as Hispanic, and 82% as white. Of course, our demographics are rapidly changing in the US, and Dr. Liz Cromwell used that information to project what our population might look like in 2042. You can see that most of it is pretty similar, but the number of people who identify as Hispanic is going to go up almost to 12%. So these issues of racism and bias and the social determinants of health will continue to be relevant as we move forward. So to this point, I really focused on race and ethnicity and bias and racism as part of the social determinants of health. Another huge factor is socioeconomic status. This is also data from the US patient registry. On the y-axis is percent of individuals, and on the x-axis is their type of insurance. You can see that about 11.4% use Medicare and or Indian Health Services. About 40% use Medicaid and or other state programs, and about 2.4% use TRICARE or other military health plans. So a significant proportion of people with CF are reliant on these state and federal programs that are under serious threat right now. Further, almost 50% of people, which includes some people who have private insurance, participated in a patient assistance program because their needs were not being met. Why does this matter? Because socioeconomic status impacts health and mortality. O'Connor and colleagues looked at people based on their income. On the y-axis is a percent predicted FEV1. On the x-axis is the age of the child, and the different color lines represent the different household incomes, with the top blue line being greater than 50,000 and the bottom dotted line being less than 20,000. You can see that the lower someone's income, the lower their percent FEV1. And not only that, but the lower their income, the more likely they were to die. In work by Erica Van Sitters and Olivia Dieni, they actually surveyed people with CF about their social needs. What they found was that 40% of people with CF have experienced at least one health-related social need in the past year, including things like food insecurity, housing insecurity, utilities, so gas, water insecurity, transportation challenges, and dependent care challenges. The blue lines represent the percentage that were receiving patient assistance. You can see that those gaps are huge. So I've given you numbers and statistics about the impact of socioeconomic status. But I think it's really helpful when we can actually hear from someone who's experienced that firsthand. So at this point, I'd like to turn it over to Ms. Rose Williams.
I am Rose. I live with my mom for support and financially because I am disabled. I have never worked in my life due to my cystic fibrosis. I actually live 4 hours away from my lung specialist up in Denver, Colorado. So it's a constant travel, 4 hours there and 4 hours back every 3 months. Winter times it's a struggle because of the mountains. You get a lot of snow and you can't get through. I have insurance provided by the government to help maintain my cystic fibrosis and get all my medical needs taken care of. So why can't I have the insulin pump anymore? Is it the insurance or what's going on there? Some of my insurance will limit my care. One of my medications for breathing treatments was denied by my insurance, and we have been fighting for a week and a half to get that appeal covered. And the struggle is the fact that I haven't had that medication for 2 weeks now. And the waiting has been honestly excruciating because I haven't been able to breathe like I used to do. I haven't had the energy to do the things I love to do, let alone the energy to take care of myself. And so that caused a lot of frustration and anger and a little bit of the anxiety. Are you guys gonna do it yet? Am I ever gonna get it, or are they gonna keep denying it? Another example would be vitamins. Like a lot of them were covered like a year ago, and now in the last month, about 4 of them have now been over-the-counter medicine that I have to pay out of pocket. And so that takes out a lot of the money that I need for other things, or just in general of life things like shampoo and all that, to just buy a simple vitamin instead. And it usually makes me very angry and frustrated. And that's where one of the things that going to therapy helps out with. It's a medication I need for not dying. And so it heightens that frustration and the struggles with cystic fibrosis when they do that to you every now and then. The resources that have helped me throughout my life, one of them would definitely be my mom, when she can. The other ones would be through my insurance of Medicare and Medicaid. They have helped me reach out to others, or they do it themselves. HealthWell Foundation helps me with vitamins. And then anybody else would be through my cystic fibrosis team. I wish I had access to the latest technology to manage my cystic fibrosis. Like at the moment, I have the vest that has been amazing to my life. I'm not tied to a wall. I'm able to do things and just throw it on and go. The one I would love back would be the insulin pump. It actually let me have a little more free time to take my blood sugar and then do my insulin for my food. But they limited that by taking that away, and then whatever else out there that these people are making to make our lives a lot easier. What keeps me going on a really hard day would definitely be my dogs. I am a big animal person, but I also am a very oriented with my family. I also do a lot of different sorts of things like crafting, photography. It gives you something other than cystic fibrosis to think about.
Thank you so much, Rose, for being open with us. And I know you're online, so thanks for being here today. So I spoke to you about how the social determinants of health impact clinical care, but it also impacts clinical research. Dr. Tiana Milnick looked back at the studies that have been conducted through the CF Therapeutics Development Network and asked, what has participation been like by race and ethnicity? On the y-axis is a percentage of people who participated in the trials. The dotted line across the top represents the proportion in the registry. So you can see that people with CF who were white were invited and participated in clinical trials at the rate you would expect based on their proportion in the registry. But for people who were Black and Hispanic, they were much less likely to be in clinical trials than you'd expect based on the proportion in the registry. This matters for a lot of reasons, but one of those is that in phase 3 trials, people are often given very early access to medications for years before others have access. People with CF who are Black and Hispanic had much less likelihood of having that opportunity. Dr. Milnick went on to talk to people about their experiences. This first person said, in Latino families, we've been brought up not to share personal information or be careful what you say in front of professionals because they could take you away. Of course, that's even more critically relevant at this moment. Another person said, lots of microaggressions, lots of passive aggressiveness, and different expectations placed on me versus white patients. A third person said, I think really asking folks what makes you not want to participate and finding out those answers and starting from there. So just don't assume because of someone's looks or their finances that they don't want to be in a trial. You need to ask everyone. So how do we get from our current reality to justice? There are a number of steps that we could take, such as becoming more trustworthy, improving timely diagnosis, identifying barriers to care and therapy, and expanding treatment and research opportunities. And in the last few minutes, I'd like to give you a few examples. So I told you that historical and ongoing mistreatment lead to medical system distrust, and that compromises patient and family provider relationships and leads to poor health outcomes. The American Medical Association, in fact, says that building relationships of trust with patients is fundamental to ethical practice in medicine. So effective bidirectional communication is key. Fortunately, there are programs, in fact, by the CF Foundation, there is one called Partnership Enhancement Program, where you can learn to better communicate with your patients and families, and therefore help improve their health outcomes. Another example is by making early diagnosis and treatment accessible to everyone with CF. This group recently came together and created new guidelines for newborn screening. And in those guidelines, they say, don't just test for F508del, the most common variant in those of your Northern European ancestry, but rather test for all the mutations that we know cause CF, so that everybody has a chance to be diagnosed early and treated early. We can also identify people's needs. Dr. Gabriella Oates is currently surveying patients and their families about their social needs. She's going to use this data to create a screening tool that can be given to all the centers across the United States. And then people can actually use that to screen their patients and families, identify their social needs, and intervene earlier. We can also expand the opportunities for people to take modulators. This is also data from the USCF patient registry. On the y-axis is a percent of individuals. On the x-axis are those that are eligible for the newest drug, Alyftrek. You can see that the majority of people who are white are eligible for Alyftrek. That's still much less true if you're Black, Indigenous, or Hispanic, or a person of color. Dr. Martin Mentz is actually working on something called theratyping. In the CF lab, he is testing cells with rare mutations and seeing if they respond to Trikafta and Alyftrek. And in that way, hopefully making it more possible for lots and lots of people to take modulators. We can also make it possible for more people to participate in clinical trials. In a study that's being led by Dr. Deepa Kapolanini and Nicole Mayer-Hamlet, called the Research Expansion to Advance the CF Therapeutic Pipeline for People Without Modulators, or REACH study, they are actually prospectively enrolling people with the hope of collecting data that will help us move forward the genetic therapies that we're studying. But critically, they are using universal screening. So every single person who is eligible for this study that walks in the door is being asked whether or not they would like to participate. So it's not, have you participated before? Do we think you have a ride here? Everyone is being asked. And of the 136 people they've enrolled, 8% are Black and nearly 20% are Hispanic. Much higher numbers than we've ever seen in CF research. Finally, we can continue to work on therapy for everyone with CF. The current genetic therapies that we are studying, many of them would work regardless of someone's mutations. We're also continuing to try to develop therapies for the signs and symptoms of people with CF. So in summary, race and ethnicity are social constructs, but they also serve as proxies for racism and bias, which are part of the social determinants of health, along with things like socioeconomic status. Those profoundly adversely impact health outcomes. But we can intervene. We can become more trustworthy. We can make early diagnosis and treatment available to everyone. We can expand research opportunities and improve our communication with patients and families. So now that you all know better, let's return to our centers, to our labs, to our research units, and do better. Now, I very intentionally focused this on the US, but I do want to acknowledge that care and treatment options aren't equitable around the world. This map shows countries in green that have access to modulators as of April 2026. You heard Dr. Clancy say there's another drug that may be available from Bangladesh. There is also a drug that's currently available in Argentina that is a bioequivalent to Trikafta. But there are some countries, like those in light blue, who can't afford these medicines, and they're receiving donations. But there is a huge part of the world where they have no access to these medications, and often don't have diagnosis and care facilities for people with CF. In just a minute, I'll invite my colleague, Dr. Hector Gutierrez, out to talk to you about what's being done in the rest of the world to create more equitable health care for everyone with CF. But before I do that, I would like to say thank you to the people with CF and their families who have been willing to provide their energy and voices to increasing awareness and who have participated in research. Also, to those organizations like the CF Foundation and individuals who are using their sphere of influence to affect change. I can't not thank the wonderful people who helped with these slides, Genevieve, JP, Jessica, Namrata, Jose, and Ali Sue, and also those who provided slides, including Martin, Ann, Deepika, and Nicole. And again, I thank all of you for sticking around on a Saturday afternoon, including those of you who are online. Thank you. With that, I would like to welcome to the stage colleague Dr. Hector Gutierrez.
Pretty good for a Saturday. So we close home today. Well, greetings everyone. First, before I start, I want to thank my family, my loved ones in Birmingham, Alabama, and my extended family in Chile. They really were the ones who allowed me to do this in my professional career. So it is a privilege to share the story of the Train the Training program. It's a collaborative effort to bridge the gap in CF care in areas with limited resources. This effort started with a simple question. How can we expand the benefit of high-quality CF care in resource-limited areas in a way that is practical, scalable, and sustainable. I'll guide you, or I'll try to guide you through the development of this model from a proof of concept to an international network, and how it's helping to build local capacity, multiply expertise, and promote equity in CF care. So ultimately, this is not just about training. It's about transforming systems, making sure that every person with cystic fibrosis, regardless of where they are, where they're born, they have access to the same quality of care and hope. So these are my disclosures. And now, the objective of this next few minutes. First, review a global disparities in CF care briefly, introduce the train-the-trainer concept and approach, walk you through the program's expansion, review its impact on care and also outcomes, and conclude with a brief discussion of feasibility, lessons learned, and global collaboration. So, across the world, their access to CF care remains deeply unequal. We know that. First, you see there are development barriers that influence health system in many low and middle income countries. There's income inequality, infrastructure gaps, human capital limitations, and limited system capacity. They have many needs. So these challenges impact all areas of health care, including CF. Next are the care issues specific to CF that arise in this context. First, delayed or misdiagnosis, lack of suspicion for diagnosis as well, inadequate provider training programs, fiscal constraints, and limited access to therapies. So together, these barriers lead to a situation where people with CF in low-resource settings have different life expectancies compared to those in high-income countries. This unequal access underscored the need to innovative, scalable, cost-effective, and sustainable approaches. So when working in low and middle-income countries, we should focus on high-impact, low-cost interventions, things that are both achievable and sustainable. So first, you see there, build local expertise. Local is the key. By training multidisciplinary teams, this approach is highly feasible. The people is there. They just need to play better, know, and learn, because it utilizes the existing resources. Second, we need to enhance the basic care. We always tell the patients, just stick with the basics, and emphasizing airway clearance, nutrition, and infection prevention. Third, we need to develop registries. We need to manage data. In God we trust, all others bring data. That is a prime directive of quality improvement. So this developing registries, an affordable digital platform, will enable us to track outcomes, know what we're doing, compare progress, and sustain improvements over time. So the guiding principle is simple. Begin with what works and build on what succeeds. So we need to explore potential solutions for this problem. Our proposal includes interventions that are cost-effective, feasible, scalable, sustainable, and more importantly, they're also enhanced expertise. We can transfer that know-how. One trained team can mentor others locally, and they create an exponential impact. A simple way to define the train-the-trainer program is this. It's a structured capacity building method where experienced teams, we have several, many in the US, are trained to become trainers themselves. We use the mentors in the US and transform other teams who can become trainers. Enable them to mentor and educate their peers in the region. In CF care, the model fosters a sustainable multiplier effect. Develop local expertise, strengthen multidisciplinary teams, and expand access to high-quality care across nations and regions. So our program has 5 core elements. Hopefully you will understand it because they're very simple. First, you need to select a team that wants to improve. Team selection is important, step 1. Then we need to train that team to become first a high-performing team. Third is they are playing well. Can they become coaches? Are they willing to do coaching in their region? Then we train them to become mentors, another kind of curriculum that we will mention in a minute. We help them to peer selection, to peer with those other teams that work like them to be better. And then they go on and train them in the way that they were trained before. And the cycles repeat. This structure ensures that knowledge transfer is continuous and sustainable. So, there you have it, that's the concept. Has this program been impactful? Well, we evaluated 5 core dimensions in evaluating how impactful the program has been. Is the program cost effective? Is the program feasible? Is the program scalable? Can multiply the expertise? And can be sustained. So teams have improved processes and outcomes without major new investments. They have expanded a network through mentorship and proved that trainees could become trainers, the defining feature of the program. So when we think now about cost effectiveness, we are not just talking about spending less. We are talking about doing more with available resources. The train-the-trainer model aims to enhance both processes and outcomes by using existing local infrastructure and personnel. They're not giving more than the know-how. By strengthening care delivery practices, improving team coordination, and embedding quality improvement habit, achieve measurable gains on processes and outcomes. So, what is the proof? Let's talk about management processes. Here what you see is the transformation that we have observed and how trainee CF teams listed at the bottom of the slide have improved their processes. Teams from Chile and Argentina. Between 2018 and 2025, they have increased the population that they care for by 11%. The families know who does better, they go there. More patients are being identified, they are engaged in care, and they're retained for the better care. The clinic visits, they're busier now, 66% increase, which reflects better access and more consistent follow-up, which is a sign of a stronger patient engagement and team-based scheduling. Notably, the average appointment time that they measure, patient goes in, patient leaves the clinic, has decreased by 20%, 27% rather. This doesn't mean less care. It means more efficient care. So through better planning, preparation before visit, team coordination, these low, middle income country settings could deliver the same or improved care than many of us in the US in less time. Patients are better served, they have more visits, more availability to the patients, and the care delivery becomes more efficient. Participating teams are strengthening processes throughout their system. They transform now care delivery. So what are they transforming? Team care base. They move from individual providers with the same desire to care for the patients that do good to a coordinated multidisciplinary excellence. They are really proactively planning. They use pre-visit planning to make encounters efficient and effective. They are using metrics. They are measuring what their impact or their difficulties are systematically, and that drives improvement. They are partnering with families, empowering them, providing families with a confidence and responsibility, which is very important, in their daily care. And they're managing data, documenting their processes, living proof that what they're doing, and we'll mention in a minute what they do with that. And they also have adaptive resilience. They continue to perform well and provide the best care possible even during the pandemic. And one of the teams had a hospital fire that affected the specific respiratory area. Now, these are processes. These are the managing of the processes. What about outcomes? They improve outcomes too, in a significant manner. I do remember before modulators, I will wait for my annual report. Our central lung function went up an average of 0.4%. The national average gain was 0.4 or so percent per year. If you do 11% in the span of 3 or so years, that is unheard of before modulators. They were doing better. Nutrition significantly improved as well, with BMI percentiles across the group of over 30%. So, processes and team-based strategies. This is nothing new for the US teams who do well here, but it's new for them. They implemented through the program are delivering measurable, better patient care and its patient-centered results. In addition, more outcomes. They have reduced their complications. 65% less chronic infection with Pseudomonas. Their 70% reduction, imagine the cost for the hospital to reduce the cost of admission in a public hospital by 70%. And the pulmonary exacerbations are decreased by 75%. This is an average of the group, which had 6 centers in Chile and Argentina reporting this data. So these numbers demonstrate that the strengthening teams and processes lead to, obviously, better outcomes. Now, one question that naturally arises is whether these improvements are simply the result of, ETI, highly effective modulators therapy. Well, our friends from Hospital Garrahan in Buenos Aires, the team closely examined their lung function trends, and they monitored the patients and divided the patients in cohorts. Patients on modulators, as expected, experienced a gain of 11%. Importantly, patients with not on modulators also showed gains, 4%. And those, when you consider the group as a whole, 6% average, 2 years. I kill for those numbers, sort of. Okay, so this suggests that the interventions that Garrahan implemented, stronger processes, it becomes kind of repetitive, you see? Stronger processes, better multidisciplinary care, improved planning, significantly contributed to better outcomes beyond the impact of modulators. Feasibility is a key question from the start. Is this doable? Could the train-the-trainer model really work in low-resource settings? It would be much easier. You go to, high-income countries, and they have no idea what you're talking, and you do it. So what we found is they can, and it did. Centers did not need high-tech solution. They needed a structured guidance, peer support, and their natural God-given creativity to succeed with limited resources. That's their environment. That's their challenge. A key part of maintaining their effort was overcoming barriers by establishing both internal and external support systems. On the internal side, we call it managing up. Go to you higher up in the hospital administration to do things. Managing teams successfully recruited they gain additional specialist support. Ideal? No, but better. Secure equipment upgrades. Just an spirometry is very needed because it's shared by the whole floor. They received direct support from hospital administration. They aim and gain protected time, very limited, but it's still better for staff to work on quality improvement work. Externally, or managing out, they reach out for other stakeholders, a strengthened partnership with parents association and patient advocacy programs. They collaborated with government agencies and CF policy. Sometimes they got what they needed, sometimes not. If not, ask Alfaro in 2018 in Chile. We didn't get it. And we spoke with the Ministry of Health in person and he was really engaged. It didn't happen. So, but when it happens, they are ready to do the next step. They can build regional peer network for knowledge sharing. They also integrated that effort to avoid working in silos. We call this a double success strategy. Teams learn to advocate outward for institutional support and resources, and outward for community support. Now, one of the most powerful aspects of the train-the-trainer model is its ability to grow and scale naturally. It's not forced, it's just a consequence. This timeline captures the growth of the train-the-trainer program, from a small proof of concept to a true emerging network. In 2014, we began with just one mentor team, us, and one trainee team in a public hospital in Santiago, Chile. The director is here, Dr. Bosa. In 2018, we doubled the number, mentors expanded, the US-based mentors were a bit higher numbers, and we expanded to 4 trainee teams in Chile and Argentina, reaching about 150 patients. By 2023, the momentum is gaining. The network has grown. We have 5 US-based mentors, 15 trainee teams, and the first group of peer mentors. They are now becoming mentors themselves, for demonstrating the multiplier effect of the model. What is going on now? Currently, we count 8 mentor teams, 21 trainee teams, and a strong network of 5 peer mentors in Chile and Argentina, with several peer trainees teams, collectively caring for over 1,000 patients. So we started with a few centers, and now we see each generation of trainees expanding the network by training others and transforming the care in their countries. That is scalability in action. Growth doesn't depend on new funding or infrastructure. Give the guy a ball, but teach him how to play, and become Morocco, under 20 world champions for the first time. Happens last week in Santiago, Chile. And do you know why who defeated? The current adult world champions, Argentina. That is a feat for Morocco. I'm serious, and my congratulations to the Argentinian team too. But so as centers mature, and they also multiply expertise, that begins as a mentorship from one team develops into a shared learning across many. And because these new trainers are local and dedicated, the model becomes sustainable. Improvement can continue. They know what is going on. They know where the shoe is affecting, not us from Birmingham. And they continue to improve after we step back. So in other words, numbers go up, centers evolve, trainees become trainers, and it is exactly the self-sustaining impact that we were aiming for. So, but success didn't come without challenges. Across all centers, they have experienced systemic barriers that hinder progress. Resistance within the system, limited institutional support, disconnected services, and access barriers that fragment care. And that is not for CF only. It affects many areas of their healthcare system. Team isolation. Many teams had few opportunities for interdisciplinary learning, and we all face barreras del lenguaje, okay? Language barriers. Some of us, I'm the only one in my team who speaks Spanish, and we have done Chile and Argentina. Imagine that. So we all face language barriers that hampered collaboration, but we overcome those barriers. Next, resource constraints have been a constant issue. Equipment, funding, reimbursement were limited, and teams often lack time, available time, no desire, time to focus on improvement. And finally, that happened to the US too, loss of momentum. Competing priorities, COVID, anyone? Heavy workloads and time constraint made it hard to maintain a long-term focus on quality improvement. As the train-the-trainer model expanded, it became clear that sustainability also depended on increasing the number of North American trainer teams. So we were fortunate to create by, in fact, the desired suggestion and vision of the CF Foundation through Al Faro to gather what we were accumulating over several years and create a curriculum that we called it the International Mentor Training Initiative for teams who are already high performers. We want them to quickly become mentors, understanding the know-how that we have gained by participating in training in these low and middle-income countries. So in a structured curriculum prepared for additional academic centers. Baylor, Dr. Fadel Ruiz is working with teams in Mexico. Columbia University, under the direction of Dr. Hussein Sadeghi, supports teams in Ecuador. Stanford University, my good friend Carlos Milla is partnering with Peru. And Harvard University, through Ahmed Ulwer, who was just last night here, is guiding programs in Jordan. So together, this initiative now reached 10 centers, nearly 600 patients, strengthening regional mentorship and ensuring that expertise continues to grow. So this is what we call the International Cystic Fibrosis Training Network, an IMTI. But importantly, the train-the-trainer model has also inspired the same concept, the same concept has inspired others outside our formal group to develop this. These are examples that you see there who, without direct affiliation with us, have applied the same principles and achieved remarkable success. University of Michigan, Dr. Samia Nassar, her mentorship had reached 10 centers in Turkey, Ethiopia, and Egypt. Her first training team is now a mentor too. Dr. Bülent Karadak in Marmara University in Turkey is moving now to assist teams in Azerbaijan and Tunisia. Nationwide Children's, led by Dr. Grace Paul, has led capacity building efforts in India and Bangladesh, reaching over 400 patients. So these examples demonstrate the transferability of the model, how effective mentoring and peer-to-peer training they can take and now expand even beyond the regional framework. So beyond the measurable outcome, it's equally important to understand how teams perceive the whole thing. Is this something that they like? Is this something that they will apply? Or, man, it was a nightmare, we are done. So, does the program truly boost their confidence, collaboration, and ability to deliver better care? To answer this, we have evaluated the feedback from participating teams using a mixed method analysis supported by our outcome research group in a UAB. So, first, the perception of team effectiveness. The chart here from 1 to 5, 5 being the best, 1, I hate the program. The chart shows trainee teams' feelings before and after going through the training process. We assess 5 dimensions of team functioning. First, boundary work and trust. They're confident in each other's expertise and teamwork. Second, team processes. The daily routines and structure that improve, leading to a smoother communication and coordination. Third, clarity. They understand the responsibilities. Focus could be too. Fourth, outcomes. Perception of real patients' improvement. Data is essential for that. And lastly, overall team efficiency. The teams felt more productive, better organized, and more effective at providing care. All dimensions assessed showed significant statistical improvement. Now, another aspect of the team assessment of the program, how they perceive their team processes. So this chart shows how trainee teams rated their work dynamics before and after the program. All areas, decision-making, communication, coordination, cohesion, problem-solving, patient focus, significantly improved. The train-the-trainer model enhances both individual skills and team functioning. As a person, I'm doing better, my team is doing better. including decision-making, problem-solving, and always keeping the patient as the central core of their effort. So, to evaluate also the program effectiveness, we use a structured Kirkpatrick framework that includes reaction, you like it? Learning, did you learn anything? Behavior, did it change your behavior? And result, what do you do with all that? You see an impact? They reported, again, high confidence and demonstrated that effective knowledge transfer, behavior change were observable and measurable, and overall competency was rated very high, showing that the training improved skills and impacted care delivery and outcomes, you saw just a few minutes ago. So this one is how they assess us. Are we good showmen? Here, each center of the participant teams that are there show that how training teams rated their mentors, with most giving top scores, 4 on 5 and 5 on the 5-point scale. And they make us better. They make us even more impactful because we were learning together. So this reflects high satisfaction with the training, the mentor's ability to build trust and adapt, and their provision of valuable guidance. We became supporters. So quantitative data aligned with qualitative feedback emphasizes the importance of the mentor relationship with them, and that is a very valuable support. Next, I want to introduce a video of my very good friend, Luis Parra, who is the center director of the hospital, pediatric hospital in Notti in Mendoza, Argentina, and he shares his team's experience with the Train the Trainer program.
Nuestra colaboración con la Universidad de Alabama inició en el año 2019. Nosotros conocíamos muy bien nuestras debilidades y amenazas en nuestro centro. Sabíamos que la atención pediátrica tenía números que, si uno los comparaba con otros centros en otros lugares del mundo, estábamos muy por debajo. Lo que más nos preocupaba era la mortalidad en la adolescencia de todos nuestros pacientes. El conocer qué tendríamos que mejorar nos hacía preguntar cómo teníamos que mejorar todo esto. Esa respuesta no la tuvimos, pero sí de alguna manera fue llevada a cabo y orientada a través del trabajo colaborativo que tuvimos con la Universidad de Alabama. Puedo decir que el cambio es absolutamente notable y puedo decir de que nuestra población ha disminuido considerablemente la internación, ha incrementado el índice de función pulmonar, ha incrementado los índices de nutrición y hemos disminuido la mortalidad. Nuestros pacientes son los principales testigos de la mejora. En primer lugar, y lo que más notan los pacientes, hemos notado una mejoría en la reducción absoluta de las hospitalizaciones. Los pacientes tienen menos exacerbaciones respiratorias. Hace una década atrás, tener un centro de adultos era para nosotros algo no pensado, no imaginado. Hemos podido lograr la transferencia de 37 pacientes adultos desde que empezamos a trabajar con el centro de Alabama. Hoy en día, el centro de adultos cuenta con casi 70 pacientes y puedo decir con orgullo que han superado nuestro número. Bien, el impacto observado a través de nuestros resultados y cómo esto ha impactado en nuestro centro nos llevó también a pensar por qué no le puede pasar esto a otros centros de la Argentina. Hemos empezado a trabajar en un proyecto, en un programa que le denominamos regionalización de la atención y pudimos de alguna manera llevar todo esto, todo lo aprendido a otros centros de hospitales de bajos recursos. Capacitar a otros equipos pasó a ser nuestra misión. Capacitar a otros equipos pasó a ser una forma generosa de poder darle a todos los pacientes con fibrosis quística que no podían llegar a nuestro centro la atención que se merecen. La trayectoria personal y la experiencia conjunta con mi equipo puedo decir que me ha llevado a posicionarme en un lugar soñado para un médico que tiene empatía, para un médico que quiere lo mejor para sus pacientes con fibrosis quística. Puedo decir que nuestros pacientes son los mismos de antes, pero que reciben otra atención, otra contención y otra calidad de vida. Eso es nuestro premio para nuestro equipo.
Gracias, Luis. Thank you for your leadership and friendship, and for accompanying us today as well. So the next phase of the program is challenging, but it focuses in connection. We have enough team now, we can connect the dots better. Transform isolated effort into a genuine learning network. The aim is to build a web that links teams across Latin America and beyond, of course, enabling knowledge and mentorship to flow in multiple directions. The ATSF Foundation is listening? This is good. Our vision is based in 4 key ideas: cross-border collaboration and learning, sharing solutions across different systems, and they find the solution. And because they have different realities than us, peer-to-peer knowledge sharing, where every team has something to teach, sustainable, locally owned expertise, ensuring that capacity persists even after we have stepped back, the external support end. And then regional problem-solving network. I emphasize problem-solving network, where centers work together to address challenges unique to their context. And I would really like to collaborate, having the capacity that UAB has. It becomes partner. It becomes a horizontal relationship, no like this. So I invite you to learn about the accomplishment of participating teams. They presented several posters, I count 7 or 8, and they were also oral presentation. These guys were not doing it a few years ago. Now they have a large contingency. So why do we do this work? Every person with cystic fibrosis, no matter where they are born, deserve access to the same quality of care and hope. That's what the Train the Trainer program is. Turn equity into action. We have proven that this model works. It is sustainable, scalable, and ready to expand through partnership and collaboration. I invite you to learn how to get involved by filling out just a few questions accessible via the QR code link there. Now, I want to thank the Cystic Fibrosis Foundation for their support, the UAB and Children's of Alabama teams, the US mentor teams, the Latin American doctors leaders, their teams, and mostly their families from Chile and Argentina, that their commitment is what makes this network thrive. In closing, the progress you're seeing today, from pilot efforts to international network, happens because clinicians, families, and institutions chose to collaborate instead of compete. It is more than just a program. It is a movement that builds capacity, multiplies expertise, and creates lasting system of care. There's still more to achieve, but together, we can ensure that access and outcomes are no longer determined by geography. And we won't stop until it's done. Thank you for your attention.
P. Clancy of the Cystic Fibrosis Foundation.
What an amazing, powerful, and inspirational story. I cannot thank Jen and Hector enough for that, and it really forces me to rethink what really is possible. So thank you both so much for that story. Before we close, I also wanted to thank everyone here at the North American CF Conference for making such a great meeting. To our speakers, thank you for sharing your knowledge, your expertise so generously with all of us. And to every researcher and clinician in the room, we are grateful for your relentless ingenuity, which continues to move promising science toward every single day in the lab, in the clinic, and by the bedside. You are the force that is behind every one of these breakthroughs. Together, we can cure cystic fibrosis, and we will make medical history. Thank you all, safe travels, and have fun tonight. Take care.